Yeah. Okay, so the question is, how easy is it to tell if overdose was cause of death? So one, I probably should mention, this is all overdoses, so fatal and non-fatal. So the non-fatal ones are usually easier to figure out, but you're correct that it can be very, very difficult to determine, to determine whether an overdose was the cause of death, based on postmortem. So people oftentimes make assumptions based on what was in the person at the time they died. And I do agree with you that that's a significant problem for our death data. The other piece being, if people die with opiates on board and somebody tests them, they are going to have opiates on board. And maybe they had a heart attack, maybe they died of an opiate overdose, but it's hard to say without having seen. Okay, so what are the implications of some of these findings? So one, we know patients are at risk even with acute exposure. So I would argue, although I know not everyone would be happy with me for this, that education and risk mitigation really should start when you start an opiate trial, not after that use becomes chronic. So we see lots of people who go, oh, no, I'm just giving them a week's dose to help them get through X, Y, or Z. But we know a good chunk of those people are never going to get off. And some of those people are going to overdose in the first week. So as much as it's extra time and so on and so forth, really, if you want to not stop overdoses, you got to teach people about overdose risk. You have to teach them to recognize it. You have to teach them what to do if they do overdose. And you got to teach them all the things they shouldn't do, like mix it with alcohol, take all these meds together, take more than I tell you is okay, et cetera, right when you start, even if you think they're only going to be on there for a week, because in some cases it'll take longer. Other thing I point out, unmanaged pain is likely a risk factor too. So we know unmanaged pain from a variety of studies increases suicide risk after controlling for depression and other factors. The other thing that people don't tend to think about is your opiates are not only painkillers, but they're also a suicide means, right? So if you have somebody who is depressed, miserable, can't cope, has really serious chronic pain that they can't manage, and you just handed them a bottle full of meds that they could just take a handful of and die, there's substantial risk for suicide. And again, like it's hard to tell if somebody died of an overdose, it's really hard to tell if somebody's overdose was intentional or accidental. And I will say, I've talked to lots of patients who don't know. I will say, was it an accident or did you do it on purpose? And they will say, well, I wasn't really very happy, but I guess I didn't really want to die, that sort of thing. And I'm like, I don't know whether that's suicide or not, but it's certainly not healthy behavior. So making sure that you address, leaving somebody with their pain unmanaged is not doing them any favors either. Even make you feel safer because you didn't prescribe them the opiate. But if you can't get them into an okay place, then they could be at just as much risk as if you'd prescribe the meds. Other piece to point out is you can't eliminate or treat away risk in most patients. So you're not going to be able to make all those risk factors disappear, but you can use risk mitigation strategies and you can monitor patients more carefully and you can manage them more carefully. So so high-risk patients, you need to start putting in place things to protect them, but you're not going to be able to make them a low-risk patient. Last, a safe dose really depends on what the other risk factors are. And one of the key things to focus on here is if you have a patient who has a lot of risk factors, it's really important that you start and agree on a lower ceiling dose. Say like, okay, we'll try you on opiates, but you've got all sorts of risks for bad things happening, for overdose or for addiction. We're not gonna just escalate your dose until everybody's happy with it. We're gonna try up to 50 milligrams, and if it doesn't work by then, we're done, right? That's as far as I think is safe, given your other conditions. And one of the things we find that's not ideal, because I know this sounds sort of obvious, right? That you would give give your higher risk patients less. It's exactly the opposite of what happens in clinical practice, because patients who are struggling with addiction, who have mood disorders, who have unmanaged pain, have all those problems, are the ones that keep coming back and saying, my pain's not getting better, I need some more help. My pain's not getting better, all these things aren't working. Which basically winds up, when you look at the data, it appears that people are purposely giving high doses to the highest risk patients. The low risk patients tend to get really little doses. They get better with really little doses more frequently. So the current dose to safety graph is completely backwards, where right now our highest risk patients are the ones who have the most in hand and are getting the highest doses. So I would say one of the things we need to focus on is just really changing that up, right? Like thinking before we start, this is where we're going with our high-risk patients. You have a low-risk patient, might be okay to take the dose higher, but don't do that. And be clear about it up front. Don't like spring it on somebody after the fact. Like this is the safe, we're gonna agree this is as high as we go because that's how far we feel safe. Other things that can help to prevent overdose, there's a whole variety of risk mitigation strategies that have been shown to help. So one is drug screening. Idea here, I told you, one, it slows you down in your prescribing, which is great. But the other part, this tells you two things. If you do your drug screens right, you should screen one for illicit drug use. So find out what the patient's taking that they may not have told you about, right? That's important to know because of the substance use risk factors. The other part that I think is really important that people don't always pay attention to is you should screen for the drug that you're prescribing the patient. You should always also ask explicitly if the patient is taking the medication that you gave them. And I know this is always framed as a way of catching people who are diverting, with the idea that this is, people who are coming in trying to talk you into giving them medication so they can go sell them on the street. And I will say that is incredibly rare, but what isn't rare at all are people making creative use of your prescriptions. So I'm just going to give you a couple examples because I would have never predicted this, but in interviewing patients, we hear about it all the time. And universally, they don't lie to their clinicians, but they also don't divulge things that weren't asked of them either. So for example, we had one patient who had been, she'd been on opiates for 3 years. She was getting her prescriptions filled every 30 days. And said, the opiates help her a lot. And we asked her, well, how do you use them? And she said, I don't use them. I stick them on my windowsill right up here so that I can see them. And when I know that they're there, I know I have something to help me if my pain gets out of control. And then I don't get worried when I'm in pain, and then my pain doesn't get bad. So I just take all these opiates and I stick them in my closet so I have something there to look at to know that I'm safe. I'm like, okay, well, that's nice, but do you really need 30 days supply for the last 5 years, or could somebody give you 3 pills to last you the weekend at worst, and wouldn't that be better? And they're like, oh yeah, I guess. But it was paid for on their insurance. I didn't care. I had another. These get even more wacky. Another patient he had a really bad chronic pain problem. So did his wife. He had insurance. His wife didn't. And he really couldn't stand watching his wife in pain. And so he got pain meds to give to his wife so he didn't have to see his wife in pain, and that made his pain go away because he knew she was okay and felt better. So the pharmacological effects of his opiates were via wife ingestion and less emoting, and therefore he felt better. Clearly not what the doctor intended. What did it effectively? Was it treating his pain? Yes, it was reducing his pain effectively. I'm not so sure the doctor would have been thrilled about that mechanism of action, but he thought it was right, and he didn't think it was doing anything wrong, right? He wasn't diverting it. He was being nice, and he was sharing the way he'd been taught to do in preschool and helping people in need, and it's not good. My other favorite, we had another guy who said, no, these really, really helped me. He was disabled man, really lonely, didn't have a lot of family or friends. They, didn't have a lot, couldn't really go anywhere. And so he said, yeah, he didn't actually take the opiates either. He just kept them. And all his neighbors, he had all these people who would like to come visit him so long as he shared the opiate medications with them. And then he felt better having the company. And so the opiates were working great for his pain because now he had visitors. So again, was he lying to the doctor when he said the opiates were helping his pain? Not technically, but that was not really how he wanted to do it. So please, the drug screening is a good way to check, just in case people don't tell you. But a lot of times they'll freely just tell you if you just ask. Don't just stop at the, is it helping your pain, but are you taking it, is the next question that's not so obvious, but it's important. So psychosocial assessment and treatment, this is just important for finding those mental health disorders and getting them treated. Also getting a sense of what that psychosocial environment is really important because, again, you're not going to, if you don't know anything about what the patient context is, you're not going to know that your patient's pain is caused by how lonely and miserable he is. You're going to assume it's like the back problem that he's complaining about. And so you need to do some of that additional assessment to try to figure out what some of the things that might be driving and contributing to the pain are. And so, bring in your mental health colleagues if you're not comfortable doing this yourself, but key component to reducing risk. Medication reconciliation, again, really obvious, but not necessarily as easy to do as one thinks. A lot of people are getting really disjointed healthcare. People don't know what everybody else is prescribing, and your patients aren't going to tell you if you don't ask. And a lot of times they don't know. I mean, I've talked to patients who've been on opiates for 10 years. They had no idea they were on opiates. They were like, oh my God, that's what that is? You got to check what they're on, have them bring in a list of all their medications, check, make sure you don't have any obvious drug interactions with things that you simply don't know about. Lastly, one of the key recommendations is never prescribe opiates to a person with an active substance use disorder without getting them treatment for it. So it's not that addicts don't deserve pain management, which is the way some people take it. There are people with addiction problems who may need opiate medication, but don't give it to them without getting them some treatment for the substance use disorder, because even if they want to, they're probably not going to be able to control it without some help. So get them the help, even if it's an uncomfortable conversation getting them there. Lastly, side effect management's important because people will not take their medications consistently if they're having bad side effects. And that's in what you wind up with when they don't take their medications consistently is people taking a bunch for a while, then they stop for a while, and then they take more for a while. And all that on and off and discontinuity and craziness not only is bad for learning, but is really, really bad for risk of, your tolerance is going to come on, come off, come on, come off. Risk of overdose is much, much higher. So help them with their constipation, essentially. And likewise, checking prescription drug monitoring programs, same concept as the MedRec. You want to know what they're taking, what they're getting from other people. I know the concept is to catch people who are doctor shoppers, and there are some people who will go to a bunch of people to get medications, but more importantly than that is just knowing what else other people are prescribing, because again, your patient doesn't necessarily know what he's being given. And I know a lot of times clinicians will assume people were lying to them. Like, I found this opiate on here from this other doctor. Why did you tell me? You told me, half the time they didn't even know what it was. They were just like, oh yeah, that guy gave me that thing. I didn't know what it was. And maybe they did, maybe they didn't. But one way or another, you need to address that in your treatment plan. Okay, I want to talk briefly. I've got more slides than I'm going to spend time on. Talking about using naloxone and overdose education and naloxone distribution as a way of reducing overdose risk. Idea here, this was developed as a way of reducing overdoses in mostly in IV substance use populations, but it's now being incorporated into general medical practice pretty effectively. General concept is that if you can train somebody to recognize the signs of an overdose and the things that are likely to lead to an overdose, you can help them, well, one, hopefully prevent it, but two, if they do start having overdose, you can teach them how to rescue themselves so that they don't wind up dead, that they get help and get that overdose reversed. Naloxone is an opiate antagonist. It will completely block the effects of any type of opiate drug. And when given, basically will revive somebody from an overdose. The tricks about it, the two main problem parts of that are, one, if you have somebody who's highly dependent on opiates, who've been on them for a while, and you inject them with naloxone, you're going to throw them into precipitated withdrawal, which, if you don't know what that means, it's basically you take all the overdose symptoms that you would get in a week and you jam it all into like an hour, right? And I used to do this with rodents. I can promise you it's not a pretty sight. It's not a fun thing. I get a lot of questions about, well, if you give people naloxone, won't they just get sloppy and just let themselves overdose because why not? And then they can have more fun with their opiates. And all you have to, if they try that once, even if they thought that was a good idea, they try that once, they will never do it again. It's not fun. And people don't wake up happy necessarily. They might be good that eventually they'll be happy that they survived, but they're not going to be happy with you probably right when they wake up. The other problem that you get with naloxone is it revives people, but it doesn't last that long. And so if you have somebody who's overdosed on long-acting opiates in particular, or have a lot of opiates in their system, they will revive, and then they will start to go right back into overdose. So people can be fine, an hour, 2 hours later, can fall back in, overdose, and die. So one of the things we emphasize to people is, we're giving this to you not because you become the rescuer, but to give the person you are rescuing time for emergency personnel to come. It is crucially important that after you rescue someone with naloxone, you get emergency personnel there just in case they overdose again. And a lot of places will give people 2 doses of naloxone just in case somebody falls back into overdose before they can get help. Sorry.